So my name is Bock, and I will talk about the question of whether beta blockers can reduce negative intrusive thoughts and anxiety in cancer survivors. And I do that by doing a Bayesian analysis of emulated randomized control trials. And this is the work I have done partly while I was at Sahlgrenska Academy at the Bock University, and while I'm now at AstraZeneca Pharmaceuticals. How to get to the next slide?
What's the question? Maybe you can practice this one. Why doesn't it work? No, you can använda den.
Okay. So the outline is as follows. I will give a brief introduction and a name. Then I will go through the data sources I'm using, which consist of questionnaire data from longitudinal cohort studies of cancer survivors. And I will use data on beta blocker prescriptions from the Swedish Prescribed Drug Register, Läkemedelsregistret. And I will use that information in order to emulate randomized control trials. And then I will use that data to do statistical data analysis of where I will analyze order categorical outcomes, and I will do that in a Bayesian setting. And I will mention a little bit how I mention missing data, how I handle that, and then I will end with some results and conclusions. And I just want to emphasize that this talk will be very brief, so I will not, unfortunately, have time to go into details. So when you receive a cancer diagnosis, that can be a highly distressing, experience with several stressful and traumatic events. And developing post-traumatic stress disorder, PTSD, is quite common in cancer survivors if you compare individuals who has not had a cancer diagnosis. And distress and intrusive thoughts can include thoughts about the uncertainty surrounding the treatment and prognosis of your disease. And intrusive thoughts have been linked to anxiety, depression, and impaired quality of life. Beta blockers are usually used for treating cardiovascular disease. It has also been used as a pharmacological treatment to PTSD and anxiety. And the aim of this work is to explore if beta blocker therapy can reduce psychological distress in cancer survivors. And I do this by doing a Bayesian data analysis of emulated randomized control trials, where I combine cohort study data with registry data. So what data do I have then? I have 3 prospective longitudinal multi-center cohort studies of patients diagnosed with prostate cancer, rectal cancer, and colon cancer. And all these patients did undergo surgery after inclusion in the trials, where the tumor was removed. And then they were subsequently followed up, and they had questionnaires to complete, such that we collected patient-reported outcomes pre-operatively before surgery, and then subsequently 12 months and 24 months after the surgery. The other data source that we had was prescription of beta blockers that we received from the Swedish Prescribed Drug Register for the period 1 year before inclusion of the trial, in order up to 2 years after the study inclusion. So I match these 2 sources of data. And if you, in general, have a scientific objective, you can think of that there exists a hypothetical trial that you can design in order to assess your research objective optimally. Let us call that trial a target trial. And for many scientific objectives, the target trial will be a randomized controlled trial where patients, for example, are randomized to intervention A or B, active or control, etc. However, this randomized controlled trial are not always possible to perform for various reasons, for ethical reasons or for cost reasons. What we then instead can do is that we take observational data and we try to emulate or mimic the target trial by doing a causal analysis of the observational data. And just a little point here is that the target trial here will not actually be a fully complete double-blind LCT, but it would rather be a pragmatic trial because we will have data from routine healthcare, we will have open label treatment, that is no blinding, and no placebo control as well. But at least we try to emulate the pragmatic target trial. Many epidemiological studies thus in general compare two types of groups. Those who has never used a therapy versus those that are current users, that can be called prevalent users. Whereas the randomized controlled trial actually randomized patients in order to either initiate versus not initiate therapy, which we can call the incident users. So that is an important distinction. With this in mind, we try to emulate randomized controlled trial in order to answer our study objective. And from our data sources, the patients that were eligible for our emulated trials was patients that was diagnosed with prostate, colon, or rectal cancer that had no previous use of beta blockers in order to have incident users. Then the patients were subsequently randomized to one of two strategies. They were not in fact randomized, of course, but we try to mimic the randomization by using a causal analysis where we adjusted for confounding variables. So we try to get as close as possible we could to randomization by adjusting for confounding variables. So then we have two treatment strategies. Either we initiate beta blocker therapy between baseline and follow-up, that is defined as the active group, or we refrain from taking beta blocker between baseline and follow-up, that is the control group. And with this design, given this design, we were able to emulate two trials actually. The first emulation, that was a trial where the time zero, we used the preoperative questionnaire as baseline, and follow-up was the 12-month questionnaire. And the strategy one was to start to take any beta blockers between 0 and 12 months. Then we could emulate a second trial where we took as baseline the 12-month questionnaire and took as follow-up the 24-month questionnaire. And then the active group was then those who initiated beta blocker treatment between 12 months and 24 months. And that is something that we call a grace period, that patients assigned to beta blockers can initiate the therapy anytime between baseline and follow-up. So when we design the trials and we have the data at hand, how do we analyze it statistically? If we let y subscript I denote our outcome at follow-up, that is 12 or 24 months, depending on its trial 1 or 2. This outcome is an ordinal scale. It has ordered categories that we can rank, and it has discrete responses, a capital J number of different categories, and we have capital N number of patients. And we try to model these response categories. So these are response categories to questionnaire questions that they have about negative intrusive thoughts and so on, that I will come back to shortly. We try to model these responses in order to see if the treatment can explain variability in these responses. And we do that by a proportional odds model. There we model the log. There we have the odds. First, we have the probability that you have that you respond to at least category J, and you calculate the odds for that. That is, you can see here, and then you take the log of it. So it's similar to a logistic regression, and we say that these log odds. You can predict that outcome by a linear predictor that depends on a set of covariates X here. And that the model is proportional in the sense that the slope beta is the same for all categories. Theta J here is the intercept, but beta is common for all categories. And the model is semi-parametric in the sense that it's a linear combination of parameters, but we make no distributional assumptions about Y here. The response categories. And in the graph to the right here, you can see an illustration of this model. So here you see the dependency between the probability of responding at least 2, 3, or 4, or 5, or at least 3, 4, or 5, etc., and how it depends on the covariate X. And if you took the logit scale here instead of the probability scale, you would see it as straight lines that would have the same slope, beta. So we want to estimate this model in a Bayesian setting. So we use a Bayesian ordered logistic regression model with proportional odds. The likelihood looks like this, where G here is the logit link function. That looks the same as for the traditional logistic regression. Yi is the outcome, and we have ordered response categories J. Small y subscript 0 is the baseline outcome. That is also is the baseline value before randomization of our question here. So y is the response of the question that the patient is answering. So small y is the baseline outcome, and x is a vector of covariates that we consider are compounding variables that we would like to adjust for in order to mimic the randomization. Theta J here are intercept for the different response categories, and delta is the difference in log odds. That is the treatment effect that we are interested in. And it's proportional in the sense that so delta will be the same for all response categories. And if you take the exponents of it, you get the odds ratio. How do we pick priors for these parameters then? Theta, delta, and beta are set to normal prior with unit variance. That can sound very informative, but recall that this is on the logit scale. So it will be very informative on the logit scale, but if you take the inverse logit of normal 0, 1 variable on the inverse logit scale, that distribution will be very vague. It will be very flat. And Richard McElrath has an example of that in his book, how he explains that one variable that is very informative on one scale can be very non-informative on another scale. And for Y, which was an order categorical predictor, we set phi as has a Dirichlet distribution, which is suitable for categorical distribution. So then, how do we estimate this? First of all, we had quite a lot of missing data in our data set, and we handled that by multiple imputations by the R package mice. And then we used 5 imputations. It can be a little bit too small, but these computations took very long time to run, so we had to keep it small. And then we estimated 5 models by the BRMS package. And then, so we got 5 posterior distributions, and we pooled them together into a single posterior distribution by the BRMS package. Then we did posterior sampling in visualizations by the tidy Bayes package. And then we presented results as posterior means and two-sided 95% credible intervals for the odds ratios. And we also derived the posterior predictive distribution across the response categories for those questions that we are addressing. This was how we estimated the models and presented the results. And if I now go to the results then, we retrieved a little bit more than 6,000 participants. Of those, we retrieved the data from Läkemedelsregistret, and a little bit more than 4,000 participants were eligible for trial 1. The eligibility criteria were that they should have not had beta blocker therapy a year before inclusion. And for trial 2, it was a little bit more than 3,000. Assigned to active group in the 2 trials was 59 and 87, and assigned to control group was almost 4,000 and a little bit more than 3,000. And the active group, there are extremely few patients assigned to the active group here. But that is because the criteria is that they have to have refrained from beta blockers, and then they need to initiate beta blockers between baseline and follow-up. And there were very few patients who did that. So therefore, we got very few patients in these active groups. So the first question, yes, please.
Yes, I'm just interested in the logic why you can't have tried beta blockers in the past. I mean, from one point of view, it sort of makes intuitive sense because it could look the data maybe. But I'm thinking like Coca-Cola will make me fat even if I'm drinking Coca-Cola in the past before a trial starts. So the effect of Coca-Cola doesn't really change if I tried it in the past. So what is the logic behind like filtering away everyone who's tried beta blockers sometime in the past before the cancer treatment starts?
That is because we have to define a clear time 0 where we initiate the treatment. Otherwise, we will not be. The definition of the treatment group will not be clearly defined. But maybe we can come back to that question a little bit later.
Okay.
Yes. Yeah. For the first question, how often during the past months have you had negative thoughts about your cancers, suddenly and unintentionally? And here we see the posterior predicted distribution for the different 4 response categories. Never, less often than once a week, at least once per week, and at least 3 times a week. And here you can see the posterior distribution for the odds ratio, and large values of the posterior distribution would favor the control group. So large value of the odds ratio means that active are worse off here. So here we can see that the active group is slightly better than the placebo group. With regard to the incidence of negative intrusive thoughts. And we did the same analysis for other variables, the severity of negative intrusive thoughts, the question, would you call yourself depressed, your quality of life, and periods of intense anxiety and panic. As you can see here, there is a very large uncertainty here in the estimate, and that is because of the very few patients in the active group. But I will now just conclude very briefly. So the Bayesian analysis enable us to do a probabilistic interpretation of the estimated causal effects. The strength of this study is that we combine registry data with clinical studies in order for us to emulate a randomized control trial. A weakness here was that we have data sparsity with few patients being assigned to that active group that initiated beta-blocker therapy. This emulated trial could not find evidence of a protective effect of beta blockers on intrusive thoughts in colorectal or prostate cancer survivors. But there is now, up to now, insufficient evidence to implement beta blockers as a prophylactic drug against intrusive thoughts in connection to cancer. So, thank you.